So good afternoon, good evening, wherever you are in the world. Welcome to this episode where I'm joined by Dr. Roger McFillin, who I heard speak only a few weeks ago. So this is such a short turnaround for me to be able to chat with you. And that's just so amazing. And I do appreciate that, Roger. And I heard you firstly on the Down to Birth podcast. So I'm currently 8 months pregnant. So that podcast is one that I am listening to. I'm very, very selective with who I listen to. And that's probably the only podcast that I've started to listen to be honest. So your topic definitely spoke to me just as a person, as a woman, as a human, but also as a professional too. And professional, I don't tend to like that word, but as a person who works with families as well. You were speaking about antidepressants and how ineffective versus effective they are. And one sentence that you said in there that I absolutely loved was, I guess your mission really is that you're trying to depathologize the normal and expected human responses. And I just felt like that was such a great summary of really the path that is serving people at the moment. And especially I see that with the families that I work with too. So for those of you new to Dr. McFillin, he is a clinical psychologist and board certified in behavioural and cognitive psychology. He is the executive director of Center for Integrated Behavioral Health in Bethlehem, Pennsylvania, and the host of the very, very popular and growing Radically Genuine podcast with Dr. Roger McFillin. He is an outspoken critic of the psychiatric diagnostic system and prescription drug culture that dominates the mental health field. He has been featured as an expert on popular podcasts and national media outlets, including One American News Network, Time Magazine, The Epic Times, and a relatable podcast with Ali Beth Stuckey, which I did listen to a few of your episodes there as well. And he does specialize in cognitive and dialectical behavioral therapies. And it's a bit of a tongue twister, that one, for the treatment of post-traumatic stress, eating disorders, and those struggling with anxiety, mood, and chronic suicidal behaviors. So we've got a really well-rounded expert here with us. So welcome, Dr. McFillin.
Jessica, it's really an honor to be with you. I appreciate you reaching out and all the kind words. And congratulations, by the way. I didn't know you were 8 months pregnant.
I am. Nobody sees my sneaky belly in these videos, right? It's always shoulders up, but she's definitely there. So thank you. So I guess one of the things that I loved, and I think we'll set a bit of a context for people, is just very quickly, I loved what happened with YouTube and Joe Rogan, and I know you've been asked about this many times, but I think it's kind of important for people to realize that this stuff happens. So can you just share briefly what happened with that for you?
Sure. As part of my mission, of course, I'm trying to disseminate some science-based information. I think a lot of information has been distorted by the medical authority in the Western world, certainly driven by pharmaceutical marketing. And when it comes to psychiatric drugs, at least in the United States, most families and consumers in the system, they just do not receive adequate information about risks and benefits. So to support my mission, we decided to develop a YouTube channel. And this was back in June. And the first video we put together was the safety and efficacy of antidepressant drugs for children and adolescents. So it was a 7-minute video, fairly short to be easily digested and to the point, which I used public research, popped papers on the video screen. Anyone who goes to Radically Genuine YouTube or my Twitter account, you can see that videos posted. Conclusions from authors of scientific studies. A lot of the things I'm going to share are pretty well accepted consensus in many areas. I think I can articulate the research base as well as clinical experience for over 20 years. And our YouTube channel, after we posted that video, was taken down in less than 24 hours. So to lose your YouTube channel because you're posting a video reporting scientific evidence was quite a shock. There was no warning. They didn't follow their guidelines. Usually there's community-based guidelines where they can take down a video and issue to you the concerns they have. None of that happened. They just eliminated the channel altogether. So what I did is I posted the video on Twitter, which is now X, and I have a decent following. Probably at the time I was like probably near 15 to 20,000 followers. So posting that video was going to get some eyes, and I had a very clear statement, like just, hey, this was taken down by YouTube. A lot of other people have been experiencing censorship. Those were who during the COVID era, we saw that much more clearly, where the voice of dissenting voices to the mainstream narrative were, either shadow banned or restricted on major platforms. But I didn't know you could completely take down an entire channel. So I put that out there on YouTube, and it got retweeted by some major celebrities, and some probably the one who's the most popular would be Joe Rogan. So Joe Rogan reposted it, and then he spoke about it on his next podcast. So he just played the video and just described what was happening, and it was an opening for him to talk about censorship. So that video it was a blessing in disguise that it got taken down by YouTube, because it has over 1 million views. And that's my mission, is I want to get the information out there. It's a matter of course that physicians and medical professionals are prescribing antidepressants at unprecedented rates, despite the serious health concerns, the adverse reactions, and the poor efficacy. And so for me, it's about assisting people to make informed healthcare decisions. And then from a clinical standpoint, I can talk about why antidepressants might be perceived as helpful for a small benefit of people, but generally why you should not take them. And so that information is part of my mission.
And I do want to get into some of the stats and the intricacies, which probably a lot of people don't know. They just take the word of the doctor or whoever they're seeing. And quite often they probably don't know the stats either, or the research, or who they're listening to might, it's a lot of he said, she said information coming through. And that causes a lot of arguments, right? It causes a lot of opinions, those he said, she said arguments. So I'm curious, because you've been doing this for quite a long time, a couple of decades you've been doing this work, and I want to know, where did it all change for you? So there was a point in time when you believed the dominant narrative, right? The dominant ideologies in this field of work. And correct me if I'm wrong, I think I read that somewhere, but based on your observations, it really changed. So I'd like to know why it changed. What were you seeing?
Yeah, there's nuance to this. My first job out of my undergraduate degree was in a children's psychiatric hospital. So it was my first observation of how children were treated in the mental health field in the United States. And these kids were young. They were ages 5 to 10 years old. Most of them were coming from trauma experiences. They came from poor families with violence and abuse, and you could see it. You could see upon their entrance into the hospital all the signs of post-traumatic stress or acute stress. And it was very difficult for them to trust. There was acting out, there was hypervigilance. And I saw then how the industry kind of worked. There was a psychiatrist on the unit who would conduct an evaluation. That evaluation was often less than a minute, asking a kid his name, where he came from, why he's in the hospital. And then it would write up an entire evaluation just based on information that they got from maybe a parent who brought that kid into the hospital. And there would be some label that was assigned to them: major depressive disorder, bipolar disorder, even at that time for children, and oppositional defiant disorder, ADHD, everything was a disorder. And I just saw kids placed on multiple mind and mood altering psychiatric drugs and deteriorate. And I was a young man. I was 21, 22 years old at the time. And I saw it as something that was oppressive and abusive. I saw some horrible side effects like tardive dyskinesia, which is like a tick of the face. I saw kids sleeping 16 to 18 hours a day, being completely sedated. So that was eye-opening to me.
Oh.
And at that time, I knew that I needed to learn more. So I can't really say that I ever bought into the narrative, but without the education and without the experience, you know, you always assume that you might be missing something. So I started on a path of education, first getting a master's degree, and then entering into a doctoral program in clinical psychology, working in many different environments, from schools to the juvenile justice system, to community mental health, to private practice, to in-home therapy. So I got a lot of experience seeing a range of different people. And I saw the same thing. I saw people deteriorating, not getting better under a psychiatric model. This idea that there are these discrete medical illnesses like psychiatric disorders, like a bipolar disorder or a mood disorder, like something that someone has, like it's tuberculosis or strep throat, you know, even though we can't observe it, we can't measure it. There's just these labels. And I had to resolve the conflict personally between what I'm told versus what I'm seeing. And my education and my background in just being able to read and evaluate scientific literature, ask challenging questions. Eventually, I started my own practice. So working in my community, I saw the same thing. People worsening, the more diagnoses they were provided, the more drugs they were provided. And the literature, which I think is like really important. I was trained as a clinical psychologist to try to utilize the literature the best that I can, and to critically evaluate and to critically think. And I think I entered into a system where people were just repeating messages and claiming things to be truth because they were told. And I worked with various psychiatrists, medical professionals. I would ask questions, like critical questions, like what is the expectation or the outcome that you would see from using this drug? What does this drug do compared to this drug? What are you expecting to have happen when you prescribe this and you withdraw them from this? What science base are you using? And one of the things that was just very clear to me is they didn't know a lot. Although they were experimenting with multiple drugs interacting with each other, it was a experimentation. Everyone would say something different. You talk to one doctor, they'd have one perception of what is happening. You talk to another doctor and they'd say, that's the wrong drug, you need this drug. They would talk about things like chemical imbalances and that they're somehow correcting some deficiency in key neurochemicals. And the hope there is that you don't really look into that, right? You just accept that they're the authority, they're the physician. You just do what you're told, right? They're the doctor. It's just not how I'm wired. So I really did a deep dive into literature, starting with antidepressants because they were prescribed the most, especially in my community. And within that, I developed a position statement based on the literature. I spoke with experts from around the world. That's where social media comes in. You're able to kind of connect with somebody from another country who's doing this research or writing these papers. And you really come to the conclusion of multiple things happening, which really peaked in the COVID era because you saw the similar fraudulent research being promoted and communicated in manners that don't fit any data. And you're just supposed to accept that narrative. So when it comes to antidepressants, for example, a number of things are true when you find this out, is they never really outperformed placebo. That it was very difficult for the drug companies, and the research is done by the drug companies themselves to determine whether this can any way outperform placebo. It doesn't. The placebo groups generally do just as well. And other than being able to maybe identify a small, what's called statistical difference between the two groups, you can do that by manipulating the measures you use or removing certain patients who worsened from the results. And in the United States, it only takes 2 positive trials for the FDA to pass a drug onto the market, to approve a drug. They're not really determining whether a drug is safe or effective. They're really trying to get the drugs to market as quickly as possible, and they need some evidence to suggest that it outperformed a placebo in a randomized clinical control trial. So you can do 20 trials, and 18 of them can show that the placebo outperforms the drug. But if you can find 2 of those trials to find a statistical difference, it doesn't even matter if it's clinically relevant, well, then you can pass that along to the FDA. And so the more you dig into this is you just see corruption at the highest level. There's what's called publication bias. They're going to try to create a trial that works in their favor. They know how to do it statistically. They know how to do it with the design. They know how to do it with the outcome measures. And they get those two published in major medical journals. They hire the academics. They hire a group to ghostwrite the paper. So often authors on the study weren't even involved in the trial. So they're just hired to ghostwrite it. And then you have other academics who are hired by the drug company for this air of legitimacy. And then you promote your drug to the doctors in conferences. You use the media. In the United States, we're one of 2 countries where we have direct-to-consumer advertising, so you can push it to the American people through television. And so you see all these various tactics that the pharmaceutical industry is able to employ to increase their customer base and their sale of drugs. One of the things that I think most people in the Western world were taught was that if you're struggling with a depression, anxiety, or other mental health condition, it is a brain condition or it's related to what's called a chemical imbalance. And they developed this theory called the chemical imbalance theory, and that even promoted and in commercials in the United States that they have drugs that correct this perceived chemical imbalance. We know now that those were lies, that they were nothing more than marketing propaganda sold to physicians, sold to the American public. And it's just seen a dramatic rise in psychiatric drugs. And the psychiatric drugs that are used have done nothing to improve outcomes. In fact, they're dramatically worsened. So I'm 47-year-old man. So when I grew up and when I was young, psychiatric drugs were rare. We didn't really hear about them. It wasn't until 1987 when Prozac came to market and into the 90s where we started to see that this was promoted as something that is safe and evidence-based. And since these drugs have been mass prescribed, we've seen increases dramatically in the diagnosis of mental health conditions. We are deteriorating as a culture. We've seen an increase in violence. A large percentage of mass shooters were on 1 or multiple psychiatric drugs. The side effect profile are very, very clear. They're documented by the pharmaceutical companies. They're documented in lawsuits. By taking any psychiatric drug, you can increase the risk dramatically of things like mania, akathisia, psychosis, worsening depression. But when we're just talking about antidepressants themselves, we have a black box warning on these drugs. A black box warning is the last step before a drug being pulled from the market. It more than doubles the risk of a suicide event. So we are giving these drugs, we are mass prescribing these drugs to our most vulnerable and youngest of population, children, adolescents, young adults. When they are struggling with their mood, when they are having suicidal thoughts, we're giving them a drug that will more than double it. None of this ever made sense to me. So I needed to be able to sleep at night. I did all this work. I needed to be able to just use it beyond my community and the patients that I saw. I needed to speak openly about it, publicly about it. So I started with social media, started a podcast, a Radically Genuine podcast. And, it's moved to a Substack. It's moved to a YouTube channel. And I'm just trying to disseminate this information because we're just seeing a deterioration in our culture. I don't even think we've begun to scratch the surface on the role and impact of psychiatric drugs on, developing fetus, for example, all the way to young children, to what it's done to our society.
I would definitely agree. I think we've got this new generation coming up, and we don't understand the implications at this stage. There's something that you said, and was, when you were young, these meds were not too popular. And what's interesting, and the first thought that comes up for me, because this is the story and the conversation that happens, but what about what if that's just because we had a culture back then who didn't want to talk about mental illness? It was still heavily prevalent back then, and now we just talk about it more openly, and we it probably was still as prevalent back then as it is today, but we're more open now, you know, because this is a common narrative that comes through whenever a statement like that is made.
It's completely nonsensical. If this were the case, if we just had this underground mental health problem that nobody was aware of, how would it be kept hidden? So we have these extraordinary rates of suicide that didn't occur then. We have elevated rates of self-injury, suicidal ideation, identified mental illness. We see more violence. We are experiencing a cultural epidemic around substance abuse. And every identifiable statistic, including things like being on social security disability in the United States, all these things have increased dramatically. School referrals, problems in schools. So we can look at that data and show we have a worsening mental health environment in our culture that didn't exist previously. So, you know, I don't think mental health is just something that you can like bury and keep under wraps without it interfering with all these statistics that are really important in employment, in hospitalizations, in early deaths, in deaths by despair. So it's kind of a nonsensical argument that doesn't fit any of the data, but you hear these things to justify the use of these drugs. Now, listen, I believe mental health and those who are struggling with their mental health deserve help. It's what kind of help, right? Yeah. That's the major question, is how are we going to frame it? How are we going to discuss it? How are we going to understand it? Because the biomedical model of psychiatry has been a reductionist model. It has no explanatory value. So if somebody's depressed, and depression's real, if somebody is overwhelmed by fear, panic, anxiety, those things are real. But why are they experiencing those things? What is happening in their life? How are they coping? What are those emotions informing them? Right? Because I'm somebody who believes strongly that our emotions are designed to serve us. They are evolutionarily adapted, and we use our emotions to be indicators that something is wrong in our life and we have to make changes. So when you move away from the time and the patience and the empathy and the caring and the skill building that's required to support someone who might be in an episode or might be really struggling in their life, and you just say, you feel this way because you have bipolar disorder, you feel this way because you have major depressive disorder, or you have ADHD. Well, how do we know that, right? It's not anything you can test. It's not anything you can observe. It's just a label without any explanatory value. So it stops the conversation for many, unfortunately, and it doesn't provide them the help they need. In fact, it's quite invalidating just to say that you feel the way you do for no other apparent reason than you have some biological or genetic abnormality.
Yeah, that's what I find too. And I find the pattern is with the clients that I work with is that we go down this path, you know, we might enter the school system and then the teacher tells the parent something is wrong, or your child has started acting out in class. Do you think maybe you should go see somebody and look at getting tested, right? Classic case. I get told this every single week. And then parent goes into freak out mode and then into, you know, what have I done wrong? And is there something wrong with my child? And then we've already got this idea planted in our mind, and then we start seeing it everywhere in the child's life. So it's becoming more obvious. Wow, well, you know, what a shocker. And then we go get the child tested, and the parents giving as much information as possible. Questions are limited. Questions are based on the DSM-5, which, you know, I do want to get your opinion on as well. And we get the label, and then we enter the medical system with appointments, right? So some parents going to 4 and 5 appointments a week. They're exhausted, they're overwhelmed. And then, you know, a year or two later, after all of this information being implanted in their mind, still it feels like chaos in their home, and still they don't understand how to best support their child. So now they're just in this whirlwind of feeling lost and alone, and nothing is going to work for me. My child is destined for failure, or they're terrified of what their life is going to look like in the future. And they also hate themselves just as much, more so, because they haven't been able to successfully help their child. So it's a really toxic cycle from what I see with the clients that I work with as well. And so I guess what I'd love to hone on into then is this field of children. And I did listen to you on YouTube, I think it was, and you were discussing ADHD, and that, you know, there is no such thing. And I know that it's a huge sentence for some parents to hear, right? And people to hear in general. We've all watched these comments on Facebook and Instagram where there's so much defensiveness and anger when we start saying something like this. And I know that speaks to the identity of it all too. So I guess I'd love to hear your thoughts on, you know, why do you say that? Why does it not exist?
Yeah, it's interesting because I like your comment about we begin to claim something as an idea, right? And when we claim something as an idea, it becomes our reality. Mm. And when that becomes our reality, we see everything through that lens. So when I say that ADHD doesn't exist, I get a lot of reaction to that because it sounds like it's crazy, like I'm a flat earther or a conspiracy theorist. But when I explain it, people understand it better. ADHD is a social construction. It's not a discrete medical illness. It's a label that we've attached. There is no biological basis for someone that is of ADHD. Now, concentration difficulties and focus difficulties exist, and so can hyperactivity. But again, it goes back to explanatory value. Think about all the reasons why someone may have a difficult time focusing: a concussion, nutritional deficiencies, a worrier because of the cognitive interference, sleep deprivation, head injuries, of course. There's just a myriad of reasons why someone might not focus in a classroom or on a sports field or something, including things like trauma reactions. Think about all the reasons that someone might be hyperactive. What we expect that every human being should be able to go into a school classroom, especially active boys, and they should be able to sit still and listen to something that is rather boring and not that interesting to them and not be outside. It seems ridiculous on its face value, but we've assigned these labels. So ADHD was first brought into the lexicon here through the DSM in 1980. Before that, there was no identification of this condition called ADD or ADHD. This was a fringe diagnosis, even going back to 1980, where it was kind of reserved for the most serious of behavioral problems affecting school, where someone could not just really sit still, right? Again, no explanatory value. The kid itself could be in an environment where there hasn't been a lot of structure or discipline. There could even be abuse. But it was that label used to try to intervene and communicate these kids, mostly boys. And it was very rarely assigned, right? And it was it was a rule out, right? Like, if I can't find anything else, I'm going to just attach this label. Since then, that diagnosis has just inflated so dramatically that it's lost any value at all. The thing is, though, I do think that people legitimately struggle with being able to focus on like stimuli that is relatively like boring or not interesting to them. And there's something that's really taken place in, the past 20 to 30 years. Most people now walk around with a supercomputer in their pocket called a phone. And we are addicted to screens and video games. There's a number of things that are hijacking the attention of people. And it's for the first time, we have generations now who are born being raised on iPads, being raised on phones, being raised on video games. It's new to human beings. It's new to child development. And what we are seeing is the brain is designed to attend, and it's a survival mechanism, to the most interesting and relative important stimuli that exists, right? So if a phone or a video game is designed to grab our attention, well, that's what kids are going to grow up in attending to. Many of the clients and families that I serve have legitimate phone dependence. So we know that if someone is on that phone for more than 2 hours a day, there is going to be some clinically relevant problems related to that. Attention, mood, a number of things. So now part of my evaluation, I'll ask clients, take out your phone and tell me what your average screen time is. So if we know that once you start going on that for more than 2 hours, we have negative consequences. Most of the clients I'm seeing 8 to 10 hours, 7 to 10 hours. Wow. And these are teenagers, these are young adults. That's how much that phone has impacted generations. And there's so many negative consequences when you add in social media. But you put them in an environment, a school environment, where now they're expected to read in a book. They're expected to listen to lectures. They're supposed to write papers, things that require sustained attention on tasks or information that generally they're not that interesting, right? So you have to like focus your attention to do something that is hard. And we've lost kind of our capabilities to do that for various reasons. And the label becomes ADHD, so much so that there's been an Adderall shortage, that there's been just manufacturing issues and getting enough Adderall out to people because that drug has been so overly prescribed. And so what I'm going to tell people is there's no medical illness, discrete medical illness called ADHD. It's a label. And it's a lazy evaluation and it's a lazy diagnosis because it stops further investigation of legitimate factors that are influencing those struggles.
Yeah. And so where do you see, and I guess this is where the DSM-5 could come in then, Roger, because I don't think that anybody has actually read through those tick boxes of what the doctors need to ask and tick when it comes to ADHD and probably various other labels and diagnoses as well. So where, you know, maybe if there's an example or two you could share, but just, you know, why do we have the DSM, right? Why is it here? Where did it come from? And then how are we misdiagnosing then? Because part of your work is, you know, that we're pathologizing the normal human experience. So where are we getting it wrong? What are we not seeing? What are we seeing, you know, incorrectly as well?
Let's start with a little bit of a history lesson here. I think first, when the Diagnostic Statistical Manual was developed, it was developed for reasons to assist in the communication generally of what psychiatrists and mental health professionals were seeing in clinical practice. So a shorthand of communication. It was never meant to be necessarily diagnostic. It was never meant to be assumed like they were medical conditions. They were shorthands, actually. Wasn't highly researched, still isn't. And, you know, it's usually, initially it was consensus of some key leaders in psychiatry. And the other purposes of it were to be able to enter into the medical system for categorizing something in a way that can get reimbursement for insurance. So I think the initial goal of DSM was pure and there was value to it. Well, it got hijacked by special interests and it got hijacked by industry. Psychiatry was traditionally and has been a medical specialty that kind of has an inferiority complex. They weren't necessarily viewed in American culture, at least, as you know, true doctors. And to legitimize their profession, they were trying to view the human condition through a biological or genetic lens. So with the advancements in medical research, I think there generally was a real push to identify mental illness as a medical condition through the biomedical model. And it was just an opportunity for the pharmaceutical industry to combine with the medical organization to really work off each other and to be able to identify conditions as in a similar way that the rest of the medical field does, which is categorical and symptom based. So if I have strep throat, right, we can do a throat culture, identify the bacteria. There's certain symptoms, sore throat, headache, fever, that would lead us to come to that conclusion. And so to medicalize the emotional and behavioral experience, they went to categorical symptom diagnoses. Major problems with that. First of all, it's ballooned to, I don't know how many are in there now, 500, diagnoses. Wow. And it's for a condition to be valid, it has to, the criteria itself has to be like widely observed and measured across settings and across people. And so the DSM lacks construct validity. It lacks validity amongst inter-raters. So what that means is that you can get 100 people to interview the same person and they might come up with 20 different diagnoses. There's these huge overlaps. When it comes to actual reality, human beings are quite complex, right? So even if you meet the criteria for major depressive disorder, you might meet criteria for 15 other diagnoses that are in there. So they're not distinct conditions, but that's not how it's communicated. And that's not how many mental health professionals are trained. They are ticking off boxes of categories, which is, again, really limiting because you're seeing a person through a symptom model, and you're now talking about thoughts and emotions as if they are symptoms. Now, we don't have access to thoughts and emotions. It's not something we can see. It's not something we can observe. So we are left up to each individual to try to understand what they're experiencing, attach a degree of understanding, and communicate whether it's normal or abnormal to another professional verbally. So you're generally relying upon someone's verbal representation of their own internal experience. And what we know is that is susceptible to quite amount of judgment and even previous learning. So if you're invalidated and you're told everything that you feel is wrong and there's something wrong with you and you're crazy, well, then you're going to learn that what you feel is wrong and you're going to communicate it to others as wrong. And so without a greater conceptualization of why a person thinks, feels, and behaves in the way that they do, and you're just ticking off symptoms, well, you're just assigning a label that has no meaning. And then you're trying to treat it as if it's any other medical condition, but without the empirical aspect of it that's so important. And now you're prescribing a drug that obviously does nothing other than to try to potentially sedate or emotionally blunt somebody to try to change their reactions or behaviors. We know now there's a lot of dangers with that. So in my world and in my country, the DSM is laughable. It's not even really utilized. It is that much of a joke. But it has sometimes the way of communicating those diagnoses and submitting things for health insurance purposes. You have to be part of that system, but no one really buys into it. And so the least trained professionals are going to see things in the simplest manner, and they end up doing the greatest harm.
And so I guess with ADHD, we have kids that get put on these medications, and we have, I don't know which is the main one in the USA that gets the most out there for kids, but we've got Ritalin and Concerta and Vyvanse. I'm not too sure if you have those in the US, and Risperidone is another really popular main one as well. So I guess for what I would love to know then from the research that you've done is, what are the implications exactly? So I know that the biggest goal for parents when they say yes to this medication, and some do it openly and willingly, and some do it because they feel like they don't have any other option. I had a couple of parents say to me the other day, Jess, how do I have my child be accepted in a school system without being on medication? because if they see that I'm not doing anything about it, they are more likely to probably suspend my child or expel my child, or I'm going to get called into so many meetings. So there's a combination of the choices and the reasons why parents go into this. Some have no idea and some don't want to do it, but feel like, well, I don't want my child to miss out on an education, right? I need them to focus. I need them to sit down so their teacher doesn't kick them out of the classroom every 2 seconds. So based on the research that you've done, and probably the research that we don't get to see, or we don't, research is complicated. It's really complicated to understand if we're not trained in the jargon and the medical lingo. What do you see as being the biggest impacts with these meds on a child's developing brain, on their body?
Yeah, there's some important things that people should know. First of all, you are prescribing a psychostimulant, a chemical derivative of some form of amphetamine, right? Where it is going to have a stimulating aspect. And they work. So they are performance enhancing for a lot of people, not everybody, in the short term. So yes, you can take Adderall, or you can take Concerta, or you can take one of these drugs, and then you can really enhance your focus. And they've learned that it really does subdue children for a period of time. And coffee does the same thing for me. I mean, I drink coffee, which is a caffeine and a stimulant. And when I'm most productive first thing in the morning when I'm drinking coffee. I feel it too. And so stimulants do work on the brain in that way, where they increase norepinephrine and other neurochemicals that are going to enhance focus and well-being. But remember, like any drug, your brain's going to adapt.
Yeah.
And you're going to need more and more of the same substance in order to experience the same result. Additionally, there's long-term consequences to taking stimulants, and to provide stimulants to a developing brain, much of what is largely unresearched and unstudied. So that when you talk about research, they're short-term for a reason. They're trying to generate some statistical difference between two groups on some outcome measure, usually very short, 8 weeks, maybe 12 weeks. But what we do know is long-term, there is no improved outcome from a kid who is diagnosed with ADHD and is placed on stimulants versus those who are diagnosed ADHD and are not. In fact, those who are not placed on the stimulants outperform them as they develop, right? So they outperform on very important measures of academic success, behavioral problems, and further mental health problems. It's of my belief that a ADHD diagnosis and the starting on stimulants is a gateway to further problems in the mental health system. So what are some of the consequences? They vary. So you can put one kid on a stimulant and they can become depressed. They can lose their appetite. They can lose their weight. Another kid could get anxious, can get irritable. In time, they could experience typical withdrawal reactions because they become dependent on the stimulant. Remember, these drugs are abused too because of the potential, the powerful aspect it has on our cognitive processing, our moods, and so forth. And people experience withdrawal from them. Adults experience withdrawal from them. The American Academy of Pediatrics doesn't recommend any child drink caffeine, but yet we are prescribing methamphetamines, chemical derivatives of methamphetamines to young children with behavioral problems. So a lot of things don't make a lot of sense. But I can tell you this, the long-term use of stimulants is associated with mental health problems, behavioral problems. It's a gateway drug, dependency. And you have to be aware of that when you make that decision. I think most behavioral problems in school and academic problems are related to things that are treatable. When you can do a behavioral treatment and have improved outcomes in comparison to going on a drug, it's harder. It's harder to implement. It requires consistency. It requires caring adults, but that's your job in a school. Your job is to understand what is happening in that particular environment for that kid and to engage and motivate them. They're children. That's your responsibility as a teacher. And The best teachers have the least amount of behavioral problems because they understand behavioral principles. They develop a relationship with the kid. If the kid is active and needs to move, they let him move. There's flexibility in the room. You get into a classroom with a rigid teacher who is inflexible, and that's a nightmare. And that's why we drive kids to these diagnoses and drugs. It's often because of the rigidity of the adults and the challenges that adults have in being able to manage kids. Then there's maturity factors. Kids mature at different rates. Kids have different needs. There are some kids that need to be working with their hands. Everyone learns differently, has different skills. Thank goodness. Could you imagine if we had a world where everyone did the same thing? Right? We don't. We have this diverse world. And in this diverse world, we have engineers, we have construction workers, we have teachers, we have mental health professionals, we have physicians, we have artists. You know, we need that diversity in order for society to flourish. But when you go into a school system and you're expected to do the same thing as everybody else, that's not respecting that diversity. And so the problem is in the education system, not necessarily the kid.
Yeah. And so if we come back to the home environment now, then, so the school context and the school environment, you know, for somebody like you who has been observing it for so long, it probably seems quite clear cut. And I think to a lot of parents I speak to, they feel like it's clear cut in terms of what needs to evolve and adapt to and change as well. So if we go back to the home environment, then and let's just say, you know, the most common thing that a parent comes to me with, and I know you work with parents, so I'm not too sure if it's the same for you or really different, but in the Australian context, you know, I get a lot of parents who say, you know, self-regulation is an issue. Meltdowns are just too extreme. Tantrums, meltdowns, too extreme. I don't know how to manage them. The anger outbursts, huge. Right. Keeping in mind that, you know, all these are quite subjective too, aren't they? Right. So each parent will have a different level and threshold as to what's normal or not normal in these realms. But so they'll come to me with that. And let's just say the school system hasn't said anything, and we've got a concerned parent and a parent who sees the child and, okay, this child needs to be fixed and needs to be changed. Right, that's a pretty common narrative that we see over here. So what in the home environment, what do you see as the biggest changes or considerations that need to be made for kids like that?
Yeah, it first starts with a pretty thorough functional analysis of the things that are happening. So when kids have behavioral problems, it's serving a certain function. And it is getting a reaction or response from the environment, and learning is so important. There needs to be structured discipline in a home, and there needs to be a consistent approach to that in order to teach kids how to self-regulate. So when I'm father of 3 kids, they're older now, but when they were younger, we used this behavioral program called 1, 2, 3 Magic. It was a timeout-based system, and so tantrums are quite normal for various points in development. They get more intense and they get worse as they get older. So if they were not taught and there wasn't that structure, that reinforcement, the consequences that existed in the environment where they were taught how to learn how to behave and how to self-regulate, well, then you're going to see kid problems become really nasty, older kid problems. And so that can become outbursts and so forth. So we have to analyze what is happening. One of the challenges that exists in the United States is part of our economy. Most of parents are now working. So, you know, kids are going to daycare and then school. They don't necessarily have consistent attention from their parents, which is, I think, is critically important. They come home and they want to be with their parents, but their parents are kind of worn out from a full work day. And we're seeing, for the past 20 years, I mean, we've just seen kids being pacified with television or screens, which has really harmed the interaction between parents and kids. And parents are struggling with how to deal with the normal developmental outbursts that occur. And so parents don't always understand there's a function of a behavior. It's been reinforced. You know, they react a certain way because they probably get a certain need met. And you have to have a tolerance for that behavior. And my experience is that a lot of parents don't have the tolerance for that behavior in the same way. Sometimes they're in public and they're embarrassed of the behavior. They give in to things.
Yeah.
At home, they're too tired. There's a lot of inconsistency. And
Mm.
so without analyzing the situation, it does require it does require full observation over time and then assist parents with skills in a structured way. My experience is kids adapt very quickly. And the problem is not the kids, the problem is the adults. So tried and true when it comes to children, consistency and structure and love and attention and having to learn within the context of that environment. And other things are important too, right? You can't get addicted to screens early. The foods that you eat matter, right? The sleep that you get matters. Kids who are at the age of needing to have naps and don't have naps can be nightmares at certain times of the day. So there's so many critical variables, but parents do have to be taught the skills, and they do have to have the support in order to provide that structured environment and know their own kids' needs as far as like attention and movement and other things.
Yeah, and I think parents understanding their children's own needs gets a bit washed out when we have so much noise outside telling them what's right and wrong. And I think that causes a huge issue as well. And something that you just said, because I know as soon as you said the word discipline, I can hear the parents who will say, well, that's the old school, right? So I know that we, in our parents' generation, their parents' generation, we had a lot of authoritative parents, and used a lot of discipline. And I know we've swung the pendulum, and we have there's movements now where it's kind of the opposite. It's, be super flexible. There's these terms called peaceful parenting. And I know they started out with really great intentions, but I think the connotations around that term has evolved and shifted as time goes on too. So we have parents not knowing, where does love and consideration and flexibility finish, and where does structure and this word discipline, because it gets a really bad rap. So how do you make peace with those two coming together in this world, in the families that you work with, and who think, well, that's just going to screw my child up, basically, right? Because that's how they felt about their parents.
Yeah. Good question. The road to hell is often paved with good intentions. Yeah. And I think when the pendulum swings to the opposite side, you have a lot of parents who are parenting in fear with these erroneous beliefs that if they are more authoritative in their home, that they're going to be doing some damage. So to me, it's with love and logic, and there's a middle path, right? And this dialectical way of thinking is really important. You need to have structure with flexibility. You need to have a firm hand with love. All these things can coexist at the same time, but you cannot parent in fear. Kids need their parents to be authoritative, but to view it from a loving perspective. Kids are not developed enough to be on their own and to make all their decisions. And that we don't know anything about child development that suggests having a permissive household leads to better outcomes. We know that authoritarian, controlling, and punitive and abusive households lead to poor outcomes, but so do permissive ones. Yeah. So, the middle path is one with structure and consistency, but in a loving way. You can implement consequences without raising your voice. You don't have to physically harm a kid. A kid can tolerate time being in their room in timeout. A kid can tolerate not having access to an iPad or a phone. There's so many various options, but they learn through consequences, and we all do. And there's an appropriate and respectful way to be able to act. And we also have to learn to be able to regulate our emotions to get the things we want. So if we're getting things that we want through screaming or yelling or tantrums or throwing things, and no kid is going to be able to develop in a way to develop the skills to get the things that they want, even verbally. So you have to model it and you have to practice it. But you bring up a good point. The middle path around this is really important. I have a brother who has a 3-year-old right now, and so I get the exposure to some of these fringe ideas on parenting that make a lot of parents feel guilty. Just being a parent makes them feel, they feel guilty having to discipline their own kids, and I think that's a recipe for disaster to view it that way.
Yeah, sure. So I guess the final question, what I'd like to end on is, because I think we can, it feels a bit hopeless sometimes, hopeless in this context, this world, this system, because it is just so ginormous. And we've got, we're the little people on the ground, right? We're the little people who, and the parents I work with on a daily basis, they're all just trying to live their lives as best they can and deal with what is being presented each day with the knowledge they currently have. So I guess from who you're talking to, from what you see, from the research you're doing, where do we go from here? What changes are you seeing, right? What are you seeing that's hopeful? And I guess, where do we still need to move on things? Where do we still need to have some focus on and the attention on?
Great question. And it's good to end optimistically, because I am hopeful, because what I am seeing is that old structures that have not served people well are starting to be broken down. The pathologizing of the human experience is now being questioned. We have a large community of harmed patients from this model, from the psychiatric diagnosis, multiple drugs. They've gone through the system. They've been harmed. We have professionals, psychologists, psychiatrists as well, medical professionals as well, who are now becoming outspoken against the narrative. There is a movement that is growing. There's an awakening. And that reclamation process is necessary to advance us as societies. That we have made critical errors in how we view people, how we treat people in the medical system. The allopathic medical system, where drugs are healthcare, across the board, is failing the health of all Western societies. And if for all those who are paying attention, we're looking now at toxins in our environment, food that we're eating, the rising rates of obesity and metabolic illness, those impacts on mental health. The structures in academics, schools, the medical system, all are under question. The medical authority is no longer being blindly accepted. The mass use of vaccinations without evaluation are being questioned. These are important things that we have to do in society in order to reclaim old ideas that are broken, that are false, that are only serving the pharmaceutical industry. And I believe in humanity. I believe in the collective goodness of us all to have these critical conversations and to make needed change. In my center, we are getting people off psychiatric drugs. We're partnering with physicians. They're safely tapering off drugs. They're restoring their health, and they're getting better. We have more information right now. Even today, I had an evaluation on a young girl who was prescribed an SSRI and had a manic reaction, and then was told by their psychiatrist that they have bipolar disorder. And then she was put on 3 more drugs, and she was abruptly tapered off the SSRI, and she feels horrible. And I was the first person that told her there was a drug reaction, that no, she doesn't have bipolar disorder, that this is a known drug reaction in her age range, especially to an SSRI. And the other drugs they've put on her are making her feel unwell. And no, you're not mentally ill. You're not sick. You're not the problem. It was the treatment. And so being able to have those conversations, the fact that I'm in the United States and you're in Australia, you and I are able to have this conversation, from a podcast. It's starting to replace major media outlets. And it's getting promoted. These ideas are getting promoted. The chemical imbalance lie is now being communicated to to the rest of the world. It's starting to become more mainstream, even though many industries are trying to hold on to it. So I just believe in where we're moving, just culturally, where we can make those changes. But it's going to require courage. And parents are going to have to question the medical authority. They're going to have to demand informed consent. They're going to have to ask them to be accountable and responsible to the treatments that they're providing and the ideas that they're providing. We no longer blindly accept your statements. Right? We know that now. I think COVID, as horrible as that was, at least began to facilitate this awakening for many. And we're in a Western society where we're all in sick care systems and we're getting sicker. And so now we can rely back on common sense, and then we can try to reclaim our health, our well-being, and try to change the way we educate, the way we interact, the way we treat each other. It's all opportunity if we see it that way.
Yeah. And if we start asking some questions, the right questions, probably the questions that we're too scared to ask sometimes. So it all starts with conversations like this and to hear bold statements like you are putting out there. So thanks so much for joining me today, Dr. McFillin. It's so great to hear all of your expertise and your views on these topics, various topics. For everyone, just as a side note, an SSRI is an antidepressant. So just so you know. But I will have all of the socials and the links to Dr. McFillin's podcasts and everything in the notes. But just where's the top place for people to go to hear more of you?
Well, the Radically Genuine podcast, you can download on any of your major apps that you use, whether that's Apple or Spotify. I also have a website, drmcfillin.com. drmcfillin.com will allow you also to have access to our podcast episodes. You could also sign up for my Substack there. It's free, weekly publication, drmcfillin.substack.com. You can get that from my website. On Twitter, or which is now X, at Dr. McFillin. And we recently kind of jumped into Instagram as well, trying to get the message out there, and that's at Radically Genuine. And don't forget the YouTube channel, the infamous YouTube channel that was taken down in 24 hours. That's again at Radically Genuine.
Yeah, perfect. And I will be sharing the very episode that caused all of that ruckus with YouTube. So I will have that in the show notes too for people's curiosity, because I sure was curious too. So thanks again, Dr. McFillin. It was great having you here. And let's keep asking those big questions.
Thank you.